So it's a great pleasure to welcome Joseph Kambeitz. Joseph is, like Andres, our previous speaker, duly qualified as a psychiatrist and a psychologist. And he's a professor at the University of Cologne, where he works in an early intervention in psychosis clinic. And his particular interests are in the early recognition and treatment of psychotic disorders, including the role of artificial intelligence and machine learning. So great looking forward to your talk. Joseph, welcome. Thank you.
Yeah, good morning, dear colleagues. It's a great pleasure to be here. Thanks for having me. I can start where the previous speaker was ending. It's about the labels. I have an example here. This is the DSM-5. The low reliabilities were already mentioned. And I want to present to you a perspective of where we can go from there. But first, I want to maybe look a little bit backwards and shine the light on how the first categorization of mental illness have been conducted. This goes back to a census in the US in 1840, and this is maybe the first example. And there was a very crude categorization of mental health, and it was just insanity, yes or no. And since then, of course, and luckily, we have improved. So we have a much more refined manual, be it the DSM-5 or the ICD-10 or 11, that gives us a much better way to characterize mental health disorders. And of course, if you think from here into the future, Andreas was already mentioning it, an aim could be that we need more specific and more refined diagnosis, because probably everyone would agree that those disorders that we have today, they suffer from some problems because of the comorbidity, the low reliability, and also when you think about two patients with depression, they can be very different from each other. So even within those categories, there is a large amount of variability. So I want to talk about this approach of precision psychiatry, and if you think this into the very far future, then this could be considered maybe the most refined possible refined way of categorization of patients, and that is everyone is unique. So like the treatment, the prognostics, and so on is really specific, not to a group, but really to an individual patient. So my talk is going to be about this topic and whether it's possible and what are the challenges. First, I want to also mention one of the big thinkers in psychiatry, Emil Kraepelin, and this is a book from Bleuler that was referring to schizophrenia as Gruppe der Schizophrenien, group of schizophrenia. So I think that is a nice term that already shows you that even many years ago, it was very present that this is a very heterogeneous category. So how did we evolve since then? Of course, we have now very refined tools that allow us to disentangle the heterogeneity, for instance, of schizophrenia. One example could be neuroimaging. And there is a very nice paper that was published a couple of years ago by the Enigma consortium. So this is a large consortium, and there is data from over 2,000 patients with schizophrenia, and those are the brain alterations that you can find in those patients. So it's very nice. You see this is robust, so it's a big sample from different sites and so on, and you see some alterations, and one of the most prominent ones is this one. It's an effect size of almost 0.4 for increased lateral ventricles. In my psychiatry book, I remember there were always pictures like this, maybe in yours as well, and it shows there is a normal patient, there is a patient with schizophrenia, and the ventricles are bigger. You can see it with the naked eye. But if we're honest, this is not so new. I remember meeting Eve Johnston once, and she published a paper exactly 40 years before that. This is a CT study, and that study found exactly the same. So you have normals and then patients with schizophrenia, much smaller sample size though, and also you see the lateral ventricles there. They're bigger. And also you see, this is a nice example of what times those were. The white circles are patients that have undergone leucotomy. So this is really an example of how psychiatry has changed since then. So you can ask the question, so we have MRI, we have big samples, so can we get better than just replicating findings that have been there already 40 years ago? So the challenge is that those effect sizes are rather small. So I gave you a figure, I give you a figure here, and this is how an effect size of 0.4, like for the lateral ventricles, looks like if you simulate data and plot two distributions. So you have in green healthy controls, in blue the patients with schizophrenia. And you see those distributions, they diverge a little bit, but it's very subtle. So what does this mean for clinical practice? So if I was a patient and I would come to your practice and you would put me in an MRI machine and you would measure, for instance, my lateral ventricles, then you would have a value and you could position me somewhere on this x-axis, right? So for instance here. But in order to diagnose or to say whether I'm a patient or not, you would have to say, do I come from the blue or from the green distribution? And it's practically impossible with such an effect size. So for me, the conclusion of that is that even if something is statistically significant, you could say it has explanatory power, does not mean that necessarily from that comes predictive power, that you can use it, for instance, in a clinical setting. The interesting thing is that you could say that also the reverse is true. So this is an example of simulated data. And maybe imagine that you're like writing your thesis and you're have a study where you measure two variables, X and Y, in patients and healthy controls. The healthies are blue, the patient is green. And if this would be the finding, then you would probably be disappointed because it doesn't look like that there's any difference between the patients and the healthy controls. But when you throw the data away, then you make the assumption that this univariate distribution is underlying this multivariate distribution. So this is exactly the same data, just plotted X and Y on two different axes. And in this case, you see there is really no difference. But it could also be that this data is actually coming from such a multivariate distribution, right? Because you see, if you just look at this pattern from the x-axis, you will find no significant difference. If you look at it just on the y-axis, also no difference. But if you look at it together, you see with the naked eye, there is a function that allows you to separate patients from controls with 100% accuracy. And you can just look at it. And there's a number of distributions that could give you such classification possibilities. So I take from this that also when something does not have explanatory power, so it's not statistically significant, does not mean that you could not use it maybe for predictions. So the key to all this is that our patients are very heterogeneous, and we want to find out how can we maybe predict the disease trajectory, patients with different diagnoses, and so on. And the overall aim of precision psychiatry is to then eventually to find a good treatment for the right patient and at the right time. And the tool that can help us in this context is machine learning or AI, artificial intelligence. And I don't want to go into details. I'll just maybe mention that this is basically statistical tools that allow us to process large amounts of data and to find those subtle differences in multivariate distributions that then eventually hopefully help us to make predictions, classifications, and so on. So I want to give you some examples, and I again start with neuroimaging. It's, as I showed, known that there are brain structural alterations in patients with schizophrenia. And a couple of years ago, we did a review, and we looked at all studies that used neuroimaging, different modalities, could be structural imaging, functional imaging, also some PET studies, and took this imaging data in combination with machine learning and tried to separate who is a patient and who is a healthy control. And if you look or average across all those studies, you see that you can separate patients from controls with approximately 80% accuracy. So that's quite encouraging. We did exactly the same for depression, and you find similar results. Also here, it looks like that you can separate a patient with depression from a patient with from a healthy control with 77% accuracy. There are some differences between the imaging modalities, but they are rather subtle. Of course, we don't want to do just classification. Eventually, we want to treat our patients, and this is where most people think is the biggest potential, because a lot of our treatment is trial and error. You try different medications until eventually the patient remits. And there is a very impressive paper by Adam Checkrut from 2016 that looked at depression treatment and used a number of predictors in combination with AI to predict whether individual patients would respond to an antidepressant treatment. So in this case, this was two studies. One is the STAR-D study, and the other one is the Kambeitz study. And what's interesting is that in the STAR-D study, treatment response could be predicted with 65% accuracy. And also when the authors took this model and then applied it to the Kambeitz study, so they made a validation in an independent sample, it seemed like that the accuracy was similar. It was 60% in that case. So is that now good or insufficient for clinical treatment? You have to consider that the response rate in this study, I think it was approximately 50%. So if you would flip a coin, you would be right in 50% of the cases. So 64, 65% is not so much better than that. But if you make calculations and you take into consideration that if you have a patient that would not respond and you can avoid trying a medication that does not help, that would lead to a shorter stay in the hospital. And if you scale this up to a country like the US or Europe, then you can save a lot of money and save a lot of suffering in the patient. So even if you have a model that just gives small improvements in predictions and the disorder is as prevalent and as important as depression, this can be very significant. And also what's interesting in the supplement of this paper, there is a little vignette study where clinicians were asked, do you think that this patient will respond to the antidepressant or no? And it's chance level, so it's really guessing. So if we want that those models one day are implemented in clinical practice, a key is that we need to make sure that they are robust and that they are generalizable. So if we in Cologne develop a model, we want to make sure that if you use it in London, that it works equally well. And this is a lot of this is the topic of a lot of work that I want to show you. So I lead an outpatient unit where we specialize on early detection and treatment of psychotic disorder. One big part of our work is that we want to identify patients who are at risk of developing psychosis. The background is that we know that it usually doesn't happen, that the patient wakes up one morning and is fully psychotic. In most cases, the majority of cases, there is some period, some prodromal phase before that where a patient experiences risk symptoms or subtle or attenuated psychotic symptoms that indicate that there is a certain risk that this might develop into a full psychosis. So if you look at the meta-analysis of the outcome of such psychosis risk individuals, you could say that approximately 25% of those individuals over 2.5 years develop psychosis. So that's much more than you would expect in a general population, of course, but it's also important to note that the majority, so 3/4 approximately of those patients, do not develop psychosis. Doesn't mean that they're completely fine. Many develop other disorders and so on, but this is important to keep in mind. So this is, of course, a very good use case for prediction models, because in a setting like an early detection service, it would be very helpful to know which one of those risk patients will develop psychosis and who does not, because for the risk individuals who will, we would want to administer a treatment or some kind of support, in the best case, to prevent that they do develop psychosis. So the basic paradigm works like this. We have patients that are at risk for psychosis, and we follow them up and to see who develops psychosis and who doesn't. And then we have a machine learning or AI model that takes data from the baseline time point, and we try to predict who will develop psychosis and who will not. And then we compare this with the real outcome of the patients. So we have a big naturalistic study that's called the PRONIA study, where such individuals were identified, and then we followed them up. The transition rate was a bit lower. It was just 18%, but that's also because the follow-up time point was a bit shorter. So the problem in this area is that there is a lot of papers that publish prediction algorithms, but there is hardly any papers that test the existing algorithms, right? And if we want to not just publish but use them, we need to validate them. So that's what we did. We went to the literature and identified all algorithms that were published to predict transition to psychosis in individuals who are at risk to develop psychosis. And then we took those prediction models and we didn't change anything. We just left them as they were published and we applied them to our PRONIA data set as an independent validation set. And this is the result. You see, this is 22 prediction models. The AUC is the accuracy of those models. And what you can see is there is a large heterogeneity, so some are good, some are bad. But most of them are in the mid-range. The dotted line is the chance level. What's interesting is that there are some that seem to be quite good. For instance, this model by Lenz et al. This had a prognostic gain of 13 or 11%, depending on what cases you look at, the transition or no transition. And what's also interesting is that if you look at what predictors those models used, you see that particularly those models that used both clinical variables but also cognitive variables seem to be quite good in this context. So it seems like that this combination of cognitive variables and clinical variables is helpful in this context. So another add-on in this study is that when we conducted the study, there were clinicians working in the study, and we asked them on a sheet of paper, this patient that you just assessed, what do you think? Will this patient develop psychosis, yes or no? And this was something that we just added on with no particular interest, and it turned out that clinicians are actually quite good in predicting it. It's a bit unexpected. And what's interesting is that we found a significant improvement if we combined both a clinical prediction model and what the clinicians said. So I will go into more details later regarding this interesting combination, but I think it points at an interesting thing that maybe prediction models and clinicians are somewhat complementary, and that this could be an interesting way in the future to really implement those things in clinical practice. So of course we can use many other data modalities to make predictions in psychosis risk patients. And this is what we did here. So we have a large battery of different data modalities that were acquired in the PRONIA study. So this, of course, includes cognitive variables and a lot of clinical variables, socio-demographic factors, environmental risk factors. We have neuroimaging data, so structural and functional neuroimaging data. We have a blood sample, and this was genotyped to derive polygenic risk scores. And we have the information, what does the clinician say? Will this patient develop psychosis, yes or no? So what we did was that we generated prediction models based on each data modality. So we have one prediction model that just is provided with the cognitive variables and the clinical variables, and then makes a prediction. We have another prediction model that takes structural imaging data and makes a prediction, transition yes or no. We have another model based on genetics, and we have the clinicians. And then, and this is called an ensemble technique, and we have a meta model that takes the predictions of the individual models and combines them in a most optimal way to generate the prediction. So you could maybe think about it in this way. If you want to maybe buy a car, then you ask a lot of friends about their recommendations, but there are some friends that know more about cars, so you weight their opinion higher, and this is how you come up with an overall prediction. And it turns out that this very complex combination of different data modalities and the clinicians lead to a significant increase in the prediction accuracy. So BAC stands for balanced accuracy. That's just the mean of sensitivity and specificity, and was 85.5% if we combined all this information. But what you can see is which data modalities were most relevant in this context. Again, it seems like that the clinicians played a very big role in this situation. So more on the generalizability of those models. In this case, we go back to predicting treatment response. And this is a paper that we studied, that we published at the beginning of this year. And we took data from 5 international RCTs in patients with schizophrenia that received an antipsychotic treatment. All patients were diagnosed with schizophrenia according to the DSM-4. And the antipsychotic medication was paliperidone in most cases. There were some arms in those trials that included olanzapine. What's nice about schizophrenia trials, they usually measure the PANSS as an outcome, so you can easily compare this. And you see that this is a very diverse data set. So we had almost 200 sites from 4 continents. And what we did here is that we specifically picked trials that were very different from each other. So we have, for instance, one trial, over 300 patients in adult first episode schizophrenia patients. Then we have one that is in adults, but it's in a more chronic phase. Another trial in adults in a chronic phase. Then we have older adults that were significantly older than all the others. And we have one in teens. And this was picked specifically like this to provide a hard test. How well would prediction models, in this case prediction of treatment response, generalize from one setting to the other? So for instance, from older individuals to teens. So we had different outcome criteria in this case. The main one that I will present to you is the remission in schizophrenia working group criteria. And we had over 200 predictors. This included demographical variables regarding the psychiatric history, clinical variables, biological variables like the blood picture and urine analysis, and of course the treatment randomization, so whether an individual received, let's say, paliperidone or olanzapine. So those are the results. So the first thing that we did is that we did what's called an within-trial null validation analysis. So that just basically means we looked just within data of one trial, and we generated prediction models in this trial and also tested them in that trial. So this is textbook what you should not do because it leads to overfitting. So in every data set, you have some noise, some random fluctuations in your urine analysis, in your PANSS assessment, and so on. And those machine learning and AI models, they're very flexible, so they easily fit, they model those random fluctuations in the data. And that means you will get very high accuracy. But when you take this model now somewhere else, it will not work very well because you basically model the noise, and this noise is random, and if you test it in a different data set, it will just show poor performance. So in this case, you see, maybe as expected, a rather high accuracy prediction of the treatment response to antipsychotics in the schizophrenia patients. So the next condition is that we did a within-trial cross-validation procedure. So this is, again, we take data from one trial, but now we do a cross-validation. So that's a procedure where you split your data, so this is the patients in this case, into multiple chunks. And then you use a couple of chunks to generate the model, but you leave out some part of the data that you just use for testing your model. And that's very important because this kind of simulates how well would the model perform if it's exposed to data that it has not seen before. So what you see is that in this case, the accuracy of the prediction, treatment response, yes or no, gets significantly lower. So red dot means it's significantly better than chance. Gray means it's not better than chance. So we went one step further, and that's paired trial. So this is now, we take one trial, we train a model on the data of this trial, and then we apply the model to another trial. So for instance, we take the adults first episode schizophrenia trial, generate the model, and then test it on the chronic adult sample. And we have here all possible pairs of trials, and you see that the accuracy further goes down, and you have only a few, 3 in this case, prediction models that were at all significantly better than chance. So the last one is a leave one trial out analysis. So in this case, we took data from all trials but left one trial out, and then generated models on all the trials and tested it on the left out trial. And again, you see that the model performs quite poor here. The idea here is, of course, if the model is trained on a data set that is a bit more diverse in the sense of that it includes data from different trials, different sites, and so on, that it learns maybe a little bit to handle this variability and then performs better. It's hard to say. You could say that in this case, there are like 2 out of 5 that are significantly better than chance. And here it's just 3 out of, I don't know, 20. So maybe it's a little bit better, but it's probably still far away from one would need for implementing this in clinical practice. So overall, this shows how important it is to really make a rigorous analysis of the validity and the generalizability of those models before you want to apply them in clinical practice. And it also shows that this does not work right out of the box for every possible clinical question that you want to maybe apply this to. So what is next? What can we do to really advance this field? I give a few examples here and then show also some more detailed later. So one thing is maybe just simple, more data and more compute. So most people in AI would argue that the advancements that we see, if you think about protein folding, ChatGPT and so on, is mainly a result of the availability of large data sets and big computers, basically. And maybe 2,000, 3,000 patients is just not enough to generate models that are powerful. Maybe we need 10,000 or 100,000. Of course, we're also investigating other data modalities. So there is a couple of things that are now becoming more and more available, like actimetry, speech markers, inflammatory markers, that could all be investigated, and maybe they're helpful for making predictions. Then there is a couple of papers that have investigated dynamic prediction models. So it might be informative to look not just at the value of a, like let's say, clinical variable at some certain point, but also to look at the change. So for instance, there are some papers that show in psychosis risk, the very early change in some variables might be indicative of later transition to psychosis. And maybe we need better models. It might be helpful to take into consideration how robust is a predictor when you generate the model. And then maybe we need better conceptualizations of mental health. Maybe we need an ICD-12 or something like that to come up with better targets. And then there's a lot of questions around how can we implement this in clinical practice. So one example I want to give you here, so we have prediction models for predicting transition to psychosis. We have also validated them in the Pronia data set. And at the moment we're conducting a trial because eventually it's not helpful in itself to make predictions. We want to provide better care. And that's what we're testing here. And this is a randomized controlled trials in multiple sites in Germany. And it's in psychosis risk, and we allocate them to 2 treatment arms. One is just treatment as usual, and the other one is a risk-stratified psychotherapy condition. So it works in a way that subjects undergo MRI, and then we use the algorithm from the Pronia study to predict their individual risk to transit to psychosis, yes or no. So we can quantify the individual risk of those patients. And then they receive psychotherapy, and the psychotherapy intervention is adapted to the predicted risk. And of course, this could be a way to show that such prediction models can help to allocate expensive treatments to risk individuals in an efficient way. So it's undergoing at this point. Hopefully, I can show results at some point soon. So the other aspect is maybe we need to reconsider how we conceptualize mental health disorders per se. And it's also important to consider what's often underlying the logic of manuals like ICD-10 or DSM is that there is some disorder, let's say schizophrenia, and we cannot observe it, but we can only observe the symptoms that it causes. So paranoia, anxiety, social isolation, for instance. So as a clinician, what you do is you look and you count the number of symptoms, and if the criteria are fulfilled, you give the diagnosis, yes or no. But what's remarkable, of course, is that, if you're paranoid, that might in itself cause anxiety. You don't need an underlying disease factor for that. So there are alternative conceptualization of mental health network models that focus on the interaction between symptoms. And of course, there are lots of factors like genetic, life events, or environmental factors that can alter the symptom network. One prediction of this would be that external variables can trigger a certain node in the network, which can lead to activations of symptoms. And because of the interactions between symptoms, these activations can persist even if the external stressor is not present anymore. So we investigated this, and we looked at symptom networks in patients with schizophrenia, in early psychosis, and recurrent psychosis. And we expected that in the later stages, there would be a stronger connectivity of those symptom networks. And it's a bit subtle, but if you look closely, you can see that in the later stages, you find this more densely connected network of symptoms in psychosis patients. Maybe this can also help categorize individual patients. So this is what we did in this trial. We looked at affective and psychotic symptoms in the general population, and then we looked at how does the network of those symptoms differ in different subpopulations. So this is a purely data-driven approach, and we found a number of variables that matter how those networks are presented in individual patients. So you see at the highest level of the hierarchy, we find a differentiation between men and women that apparently show different network structures. And then there are interesting aspects here. So for instance, you see that cannabis is a relevant factor that determines how those individual networks are presented, but it's only relevant in the branch of the male patients. It's not relevant in the female patients, for instance. Maybe this is a helpful way of thinking about mental health that could later on then also improve prediction models. And the last example is the following. We can also look at how events like stressful life events travel through the network. So it's well known that in psychotic patients, such stressful life events increase positive symptoms. So we investigated this in the Pronia sample again, and we also looked at general symptoms and negative symptoms. So what's interesting is that if subjects are exposed to stressful life events, it seems like that those events are not directly exhibiting an effect on positive symptoms, but primarily on general symptoms that subsequently increase the positive symptoms. So maybe this is indicative of an effective pathway to psychosis and could help to improve our predictions and treatments. So there are also important challenges that we need to consider, for instance, ethical challenges. If you think into the future where we apply such prediction models, then we need to consider the following problem. So this is an example of a paper by Ziad Overmaier from 2019, and he investigated a prediction algorithm that is already in place in the US in many hospitals. And it works in the following way. Based on some clinical variables, there is a risk score that is generated for each individual patient. And if you cross a certain threshold, you will be referred to a more detailed screening, and you're then eligible for a program where you get a couple of medical resources, like you get faster appointments in an outpatient unit and so on. So what is interesting is that in that work, the authors looked at the risk score and also at the number of active chronic conditions for the individual patients. And then they compared in the orange color patients with white skin color, and in the violet color patients with black or dark skin color. And what you see is that those lines, they diverge. So what does it mean? So if you look, for instance, here at the threshold, this is the threshold where you're referred to screening, whether you're eligible for the special program. You see that a patient with a dark skin color needs to have much more or a high number of active chronic conditions to receive the same risk score as a patient with light skin color. So how does this happen? So interestingly, it turns out that this is resulting from the fact that the algorithm was trained not to predict disease, but to predict healthcare costs. So you see this in this example. So this is again the risk score, and now this is the mean total medical expenditures. And you see here the two lines, they do not diverge from each other. But when you look at the number of chronic illnesses and the healthcare costs, then you find again divergence between the lines. So this is just a good example. The mechanism is as follows. It's apparently a fact that patients with dark skin color, they generate lesser medical expenses. And if you train an algorithm to predict expenses, then you might induce a racial bias in this prediction algorithm. So it's a nice example of hazards that come along with prediction models. The good news is, in the paper is described that the authors approached the software company that developed the algorithm and was corrected, right? And maybe it's easier to correct, I just leave it as a brief comment, maybe it's easier to correct an algorithm than the subtle biases that are maybe in some heads of the people around us. So we applied the same logic to AI models used to predict transition to psychosis in risk individuals. And we compared a number of different algorithms. So those are the ones that performed very well in our previous examinations. We also looked at the clinicians' ratings. And then we looked at two sensitive attributes. One is gender, and the other one is level of education. And what we can do then is that we create a fairness metrics. So that is basically comparing the model performance in the two subpopulations. So low education, high education, males and females. And what we see is that for gender, there was no bias, but there seems to be a bias for patients with a low education, in the sense of that there is a higher number of false positives. And this is probably because in our training data, there is very few number of those individuals that would qualify as low education, and therefore the models do not perform as accurate as we would want them to. So this is an important indicator that we need to take care of such ethical biases in prediction models, and we need to represent all relevant attributes in the training data. So the last thing that I want to present to you, I would like to start maybe with a short thought experiment. So we had a patient yesterday that was presented very interesting. There was a young lady described that had a hobby of horse riding, and then experienced sudden symptoms of catatonia, some motoric symptoms, some odd behavior, and also some psychotic symptoms, but it was not completely clear. So the colleague described that she received olanzapine. So maybe you can put yourself in the shoes of the responsible physicians, and you can ask yourself the question, there is a young lady, catatonic symptoms, would you recommend olanzapine in this case? And probably some in this room that would say, yes, yeah, I would recommend olanzapine. But maybe there are some here that would say, like, no, I'd prefer a different medication. And even the doctors here that would recommend olanzapine, they might do it for different reasons, right? I mean, we learn things in our studies, we have clinical experience, and all those are things that influence us when we make decisions. And I think that part of those decisions are conscious, but I think that also what plays a big role in the way we do clinical medicine is to some extent is intuition, right? And I think there is a reason for that, and it's helpful in many contexts, but it's also not very transparent, right? If we use our gut feeling to decide who will get which medication. So a common criticism of AI models is, well, it's a black box. We don't understand. We throw in some data and then it spits out predictions, but we don't know how those predictions are made. But sometimes I think that us clinicians, we're also a little bit of a black box. We make decisions somehow, but maybe is not completely clear to us, or at least is very heterogeneous, how we make those decisions actually. So as clinicians seem to work very well in predicting who will develop psychosis or not, we wanted to investigate this a little bit further. So we have from the Pronia studies clinicians that saw patients and made their predictions. And then we generated, after the study was finished, we generated case files based on the real patients, and we presented those case files to clinicians. And we asked them again, what do you think? So we have two conditions. We have clinicians that saw the patient, and we have clinicians that just read the case files. And then we also have the real outcome of those patients, and we have the predictions of the clinical model. So the first thing is that we analyzed is how do the predictions compare when clinicians saw a patient compared to when they just read the case file, and it does not correlate a lot. I'm not sure why is that, but probably it is because there is some information in the case file, in the real world setting that is not present in the case file. Maybe it's some information, you know, some risk factor that we didn't put in the case vignette, but maybe it's also something that's in the room there, you know, like something subtle in the prosody of the patient, the mimics, the way they move, and so on, that is picked up by the clinician and is used to make clinical predictions. But we also looked at the available information and how strongly does the available information in clinical reality and in the case vignette, how strongly is the available information associated with the decision of the clinician. And that correlates very strongly in the case vignette study and in the real world setting. So I would argue this indicates that the available information is used in a very consistent way, no matter if you read a case file or you see a patient. So there is some justification for analyzing this. And the interesting approach that we took now is that we used machine learning, AI, to understand doctors better. And we do this by taking information from the clinical information from the patients, and then we generate a prediction model, but we don't predict the outcome, we predict what the clinicians say. And then we can look at, for instance, a decision tree, and this is basically decision rules that explain how clinicians make their decisions. And this is just a couple of examples of decision rules that we find, and they're quite plausible, I would say. So you see here, just to give you one example, a rule that starts with age, and then it looks at a symptom, and then it considers age again. So basically what this means is that the symptoms, the symptom CYP1, so that's a attenuated psychosis symptom, is considered to say whether a patient develops psychosis or not, but only in a certain age window between 19 and 28. If the symptom occurs before or afterwards, is not considered. And that makes sense, right? Because if the patient is very young, maybe the symptoms is not so important, it might not be robust and so on. And if the patient is very old, maybe he's too old to develop psychosis. So I think that this is helpful to understand clinicians and then also compare clinicians and prediction models to see where is really the most promising use case for prediction models. We can do all sorts of other analysis, for instance, compare the predictions and how clinicians and prediction models use different variables. And we can also find certain biases. So this is my last slide. We also asked the clinicians, okay, you say now this patient develops psychosis with 80%. How sure are you of your own prediction? And this is plotted here. So this is the probability of transition to psychosis, and that's the subjective certainty of that prediction. And what you see very clearly is those U-shaped patterns. And what that means is that at the lowest point of subjective probability, so when you're very unsure, you don't know what to say, then raters, clinicians, they always say 50%. But that's an overestimate. I showed you before the transition rate, base rate, is like 25% approximately. So I think that this is a very interesting result that shows that in some contexts, you know, like we as clinicians might have certain biases, and correcting those, maybe with like data-driven tools, might help to provide better care to patients. So that's the end of my talk. I would like to thank the people in my lab that did all the work, more or less, and my collaborators all across the world. Thank you for your attention.
Thank you for that wonderful talk. While you were speaking, I've written an algorithm to predict who's going to ask a question and what they're going to ask, so now we can put it to the test. Ben, just wait for the mic, if that's okay.
So on the generalizability problem, the Japanese group who've looked at imaging alone argue that travelling subjects is by far the best solution to that. Do you think that using travelling subjects across multiple sites and across multiple domains of data and information is a realistic way of kind of solving this problem on a kind of national or international basis?
Yeah, so I think that's for many big consortia, that is a big problem, that you have variability that is related to the scanner vendor or the head call that you use. And we did some analysis, and it's very easy, based on an MRI scan, to predict, is this an MRI scan from a Philips scanner or a Siemens scanner? And also, if you look at which regions are relevant for these predictions, is regions that overlap with the regions that we expect to be altered in schizophrenia. So it's a big problem. I didn't mention that we have a traveling subjects data set here. And we used it in a way that was helpful in our analysis. I'm not sure if this is the best way to do it in all contexts. So what we did is that we calculated a generalizability score for each voxel. And that comes from generalizability theory, but basically the idea is a voxel is rated higher in making predictions if it shows a lot of variability related to the subjects in the traveling data set, because that's what you want, right? You want high variability between subjects, but the voxel was rated low if it showed a lot of variability related to scanner, because that's what you want to avoid. So that's what we did here. It was helpful in this context. But I think it's still an open question in the field. That's my feeling. Yeah.
Thomas.
Hi, I'm over here. Really interesting talk and great data. I think I really strongly disagreed with your last slide, though, where you have the data on the U-shaped curve. I mean, I think there's quite a lot of data from sort of general sensory experience that humans are optimal Bayesian predictors, that we take into account the base rate when taking into account the available evidence, and we come to a conclusion. There's some evidence that maybe some doctors aren't good at that, in that they overestimate rare outcomes. But I think here, what it showed was, you know, the doctors know that there's only a 1 in 4 chance of transition, and what they're expressing is that there's something that worries me about this patient, that makes me more unsure about them, and therefore I'm going to weight their rating higher. And if you wanted to show optimal doctor performance, you would want that U-shaped curve to be right in the middle. You wouldn't want it to represent the base rate, because then you have what AI does, which is just to say every patient in the memory clinic's got Alzheimer's disease with 95% certainty, because they do, but then they miss the ones where your sort of spidey sense of experience tells you, I'm a bit worried about this person, I can't quite pin down why, and that's why I'm not certain, but I'm more worried than the base rate.
Yeah, I think you're right. So I think that from my point of view, apart from the statistical issues that you mentioned, as I said, this is something that we added to the study just as a control kind of data acquisition. And maybe the way that we specified the question is also not specific enough. The base rate also differs a lot depending on the setting that you are in. And this, for instance, is not specified in the question. So even in the Pronia data set, there are some sites that are more located in medical departments and some in psychological departments. And so there are a lot of differences between the sites. So I agree with you. If you really wanted to show such a bias, you would probably need to do another study and control this more thoroughly.
I think all of us that work in different clinical settings have different indexes of suspicion, depending if it's a tertiary referral or a primary referral.
Mm.
I saw Norman's hand go up there.
Thank you. You started the talk by talking about Kreplin, and obviously he spoke about the Pareto feeling, and I just wondered whether what you're doing is kind of operationalizing the Pareto feeling, or whether that's actually something that's sort of completely separate that you're not capturing.
Yeah. So inspired by those results, and that the clinicians performed quite well, we are planning at the moment studies to investigate this in greater detail. I'm not entirely sure, to be honest, what's the best way to investigate this. So the first step is we are planning a qualitative study to first talk to clinicians to get a better idea to how we can potentially operationalize this.
Tom? No? Okay. Anyone else? Jesus.
Thank you very much for that excellent presentation. It's very helpful. And so you went through several topics, but you referred to first the classification, so the power of the brain imaging to obtain classification of the patients with accuracy, and then to prediction of response and prediction of transition to psychosis. So in the case of prediction of transition and prediction of response, I think it is clear that we have a gold standard that is very robust, because we want to know if a patient will improve, or we want to know if a patient will transition to a clinical relevant state. But in the first case, perhaps, I don't know if there is a problem in that, if we're trying to validate the categories, but we know that the categories allow for a lot of heterogeneity. Is there room there for a different kind of phenotyping, like a more precise phenotyping? I remember, for instance, a study in which the category of schizophrenia was break down into different forms, and one of them was the major neurocognitive psychosis, for instance.
Yeah.
So I don't know if these tools are used in that way, and what are your thoughts about that?
Yeah.
Like transforming the taxonomies.
Yeah, that's an excellent question. So the majority of studies that try to address the question are using clustering techniques, for instance, based on some biological data, it could be neuroimaging data, or even clinical or cognitive data. And basically, this is data-driven techniques that would identify homogeneous subgroups within the quite heterogeneous diagnostic categories like schizophrenia. So I think that this is very interesting and promising, but the problem in this branch of research is that it's so heterogeneous, like the way that those studies are conducted, how they cluster the data, which data goes into that. And to be honest, I'm not aware of a single study that did such a clustering, and the clustering was validated in an independent study. So like there was one, there is a Nature Medicine study that did a clustering. Sorry, I can't remember the first author now, like based on resting state data of depression, and it was also validated in the sense of that it showed different response rate to a treatment, but there was a follow-up paper by another group that showed that there are some methodological challenges. So I think that even this very highly cited and highly published study doesn't seem to be methodologically sound. So at this point, it's hard to say whether we can really derive new labels with this approach.
Let's keep going for a little bit. Lady in the middle there.
Thank you. My name's Nikki Shiner and I'm a psychologist. Really interesting, thank you very much. I've got a more, I suppose, high-level question, and that was your comment about gut feelings. And going back to Tom, who said about the spikiness, I believe that what you perhaps didn't accord such significance to is actually what is moving us towards more precise diagnosis. And given that it was the clinicians in the ensemble, the clinicians who had the best levels, what do you think of the future of AI? Is it an adjunctive, or is it a tool, or do you always see a role for that gut feeling, which obviously, if we break down the gut feeling, is going to be years of experience, understanding, and not just things that you can put into data sets? Thank you.
That's a very difficult question. I think I don't know what's the role of gut feeling. It's just I would be very interested in finding more out about it. Is it really something that we can identify in different contexts? And I also would like to find out what is it based on? Is it reliable? How does it differ between different clinicians and so on? I would have a hard time, I believe, to just sit back and say like, okay, gut feeling seems to work. We don't understand it completely, but let's do psychiatry using this gut feeling. So yeah, let's see what research can tell us here. Regarding your first question, that's a super interesting area of research, and I think we need to find out. The first thing is some things clinicians can do quite good. Let's say maybe diagnose schizophrenia, but some we cannot do so good. Maybe pick an antidepressant treatment, and we do trial and error a lot. And if we find out better what clinicians can do good and what not so much, we can probably find the best cases where AI could help clinicians to provide better care. And even if we found this, it's a question, where is it located in the clinical decision pathway? Is AI something that comes at the first place, that makes some crude assessment, some screening that helps the clinician to do a more detailed one? Or does it come maybe later, when the clinician made a decision, then the AI checks that? And there is a couple of, or one very interesting paper that is just a preprint, is by Google, and they did, I don't know, do you do OSCE exams in the UK as well? Mm-hmm. Yeah, so they did like a simulated OSCE exam, and then the patient actors chatted over an interface, either with a language model or with a real clinician. And it seems like that the language model outperforms the clinicians, not only in finding the right diagnosis, but also in the rating of the conversation quality, which is very interesting, I think. So those models seem to be very powerful. But again, I think for me, the first step would be to understand how is the clinical reasoning happening in those models? How is it helping? How is it happening in clinicians? And then we know how can we best bring this together to provide better care. That would be my idea for the future.
Happy to take two more questions.
Yeah, sure.
Two more, because then I don't want to eat it as a coffee break. Let's have Tom and Quintin ask your questions one after the other, then we'll have both the answers together.
Thank you. It's a similar point about intuition, or a question really, but I think relevant to this conference where we have some neurologists and some psychiatrists, and having worked with neurologists as a psychiatrist for a long time, I'm convinced that we're running slightly different software, even when we see the same patient. But I've also come to appreciate some of the quirks of their software, and I know that if I really need to get, some sort of investigation performed, there are certain clinical aspects of say a psychotic patient that might press the neurologist buttons a little bit better. For some reason, it's the sort of the formal thought disorder. I think something in the neurologist's brain sees that as some sort of aphasia, and it gets sort of it pushes buttons that maybe other symptoms won't. And I just wondered, do you see this sort of technology as having a potential to not just kind of delineate the contours of the different kinds of clinical thinking that we have, that we do, but also actually to try and build bridges and better understand, better sort of think in a way where we are running the same software?
Yeah. I'll just get Quintin's question, then I'll let you respond.
Thanks. It's a related question in a way. I was very interested in your network analyses, which, if I understand them correctly, identify relationships between symptoms and relate them to extrinsic variables. So my question also relates to the black box. Does your research, in order for your research to improve clinical prediction, require an improved account of how cognition works? So, for example, do you work with computational modelers who are interested in actually modeling how the nervous system works to support decision making? Or is what you do blind to that, and it's essentially irrelevant what goes on inside the black box? You merely need to know what the inputs and the outputs are.
Yeah. So maybe regarding the first question, absolutely, that would be my dream, that we can bring the two cultures maybe closer together and identify strengths and weaknesses and so on. And regarding the second question, well, methodologically, you can apply a prediction model without understanding how it works. And we do this a lot, right? I mean, I don't understand all the details of an MRI machine, but I use it every day. It just works, and I'm okay with what it spits out in the end. But I think those kind of predictions that we get here, they're so relevant for the patients that one reason is for safety reasons. We want to be sure that there are no like processes or biases in those models that are could be harmful for the patients. And then also there is the ethical reasons. So in the European ethical guidelines for prediction models, patients have a right to be explained how predictions were made. So it's considered to be an ethical right, and therefore I think if we want to use those models, we need to make sure that if a patient comes and says, okay, I want to understand why did this model based on my MRI say I will develop psychosis, you need to be able to explain why. How this explanation looks like is a different topic, but I think, yeah, we definitely should aim to understand how those processes work.